other agents in development, lots of development going on within the gastric field. Anti-angiogenic agents, we saw the study from China.
Yes, yes.
On ipatinib?
Yes. So I was going to come back to that. So we mentioned the AVAGAS study, which was a first-line study. Rainbow and Regard were second-line studies, and there was obviously a benefit. Also, the proportion of patients from Asia were limited in those studies. But then we have this study of ipatinib, which is a tyrosine kinase inhibitor that inhibits VEGFR2, the same receptor that is inhibited by ramucirumab, and there was also positive in the third-line setting from an Asian country, China. So I think that it's, the Asia versus non-Asian anti-angiogenic therapy is very complicated. But beyond that, I think this is actually a proven target in gastroesophageal cancers. Anti-angiogenic therapies, they do work, sometimes as monotherapy, often in combination. And I think, looking out for the Rainfall study and that result in the next year or so will be very exciting.
Yeah, and like you're alluding to, I think we're seeing more and more gastric cancer patients, particularly within the West, that are getting to third line and potentially fourth line therapies. And I think the importance of getting all the agents in there. So if you use a fluoropyrimidine and a platinum, then a taxane, you're using your anti-angiogenic agents, and then you also have irinotecan to use. So definitely options for these patients.
And then possibly a PD-1 inhibitor.
Exactly.
And for patients with small volume disease, I think anti-angiogenic therapy alone is maybe the answer to give them an opportunity to breathe without chemotherapy toxicity. In second-line data of progression-free survival for single-agent docetaxel compared to single-agent ramucirumab, historic data is pretty much right on point. In this way, you avoid alopecia, neuropathy, neutropenia, and others. So we do scan our patients and monitor them closely. And so with small volume progression, asymptomatic, it's a small liver lesion or lung lesion, that you will have time to rescue them from any symptoms, single-agent anti-angiogenesis such as ramucirumab is a great option.
And Yelena, you alluded a little bit earlier to looking at trastuzumab plus a PD-1 inhibitor with your clinical trial. So a question I get a lot, I'm sure you guys get this a lot. I have a HER2 positive patient. They've progressed on FOLFOX plus trastuzumab first line. Do I move them to ramucirumab plus paclitaxel second line, or do I continue the trastuzumab with chemotherapy or without?
It's a great question, and at the time of trastuzumab progression, actually, the data suggests, and at the repeat biopsies, up to 20% of tumors lose HER2 expression in gastric cancer, which is a pretty substantial proportion of patients. So, I think it's important to understand the tumor biology at the time of progression, and increasingly important to biopsy these tumors to understand what you're targeting. Because if the target is not there, certainly trastuzumab will do nothing, and it would be that much more important to switch to ramucirumab or other experimental therapy. Let's make the problem more complicated. Let's say the tumor is still HER2 positive. What is the data to support trastuzumab beyond progression? And I would say before the Gatsby study came out, the TDM1 data came out, I was more in favor of continuing trastuzumab beyond progression, again, extrapolating from the breast cancer data. But the TDM1 data suggests that in second line, TDM1 was not any better than single-agent paclitaxel. And TDM1, as you know, is a trastuzumab bound to another DNA-damaging agent, to cross-linker. So suggesting that perhaps, in second line, it would be okay to switch from trastuzumab to ramucirumab. And this is, generally decided on case-by-case basis on the degree of response to trastuzumab in first line, how long did the patient stay, how convinced am I that the tumor biology is dependent on HER2 signaling.
And a recent paper from Regard actually showed there was no differential effect of ramucirumab, whether it's a HER2 positive or HER2 negative. So I think, at least there is some reassurance that using a ramucirumab-based treatment is actually a reasonable thing in a HER2 positive gastric cancer beyond trastuzumab.